Welcome back to Beyond the Stethoscope, the podcast for general practitioners.
Great to be here.
We're really glad you could join us for another deep dive. This one's tailored, as always, for you, our colleagues, GPs, and especially GP registrars getting ready for those fellowship exams.
Yeah, absolutely.
Today, we're tackling a really fundamental topic, dyslipidemia. The plan is to go deep, get beyond just the surface-level guidelines, and give you a solid understanding you can use every day in practice, and of course, for the exams.
That's the goal. We're basing this discussion on Chapter 78, Dyslipidemia, from the latest Murtaugh's General Practice, the 8th edition. A cornerstone resource, really.
Couldn't agree more.
And our aim isn't just to, list facts. We want to unpack the why behind the recommendations and explore how it all plays out in real-world consultations.
Exactly. And look, the significance here is huge, isn't it? Dyslipidemia is so tightly linked to cardiovascular disease. Managing it well is central to what we do.
Absolutely critical.
It makes you think back to those landmark studies. Remember the Scandinavian simvastatin survival study, the 4S trial back in '94?
Oh, definitely. A real game changer.
It fundamentally shifted how we thought about lipid-lowering therapy, didn't it? Really showed the power it had to change outcomes.
It really did. That 4S study gave us some of the first really compelling evidence that intervening lowering lipids actually made a difference. So, okay, let's start with the basics then. What exactly is dyslipidemia?
Right. So at its heart, it's an abnormal lipid profile, isn't it? An unhealthy balance of fats, cholesterol, triglycerides, and the lipoproteins carrying them in the blood.
Precisely. And we generally break it down into three main patterns, three classifications.
Okay, let's unpack those. So first up, you've got predominant hypertriglyceridemia. That's where triglycerides are the main problem.
Correct. Then number two is predominant hypercholesterolemia, where high cholesterol, particularly that LDL fraction, is the standout issue.
And the third.
That's the mixed pattern.
Okay.
You see elevations in both cholesterol and triglycerides.
Got it. And it's crucial, isn't it, to understand how these link to cardiovascular disease?
Absolutely vital. Murtaugh lays it out clearly. Elevated plasma cholesterol, especially LDL, leads directly to those damaging pathological changes in artery walls. That's what causes coronary artery disease, or CAD.
But the flip side, the positive news, is that we can make a difference. Lowering those lipids, whether it's through lifestyle changes or medication, significantly cuts the risk of heart attacks, strokes.
And improves survival. That's the key message. It genuinely saves lives and prevents major events.
And the evidence for this is strong, right? The chapter mentions the Cochrane review on statins.
Yes, the 2013 review, really high-quality evidence showing statins reduce all-cause mortality and major vascular events. It's about as solid as evidence gets in medicine.
Which brings us to a really practical point, the number needed to treat, the NNT. Table 78.1 in Murtaugh breaks this down.
Yeah, this is super useful for clinical practice and for explaining things to patients. The NNT tells us how many people need that statin for a set period, usually 5 years in these tables, to prevent one major event.
So let's look at those numbers. For someone with less than 5% 5-year cardiovascular risk,
Yeah,
the NNT is pretty high, right?
it is. It's 835 according to that table, meaning you treat 835 people in that low-risk group for 5 years to prevent one event.
Okay. But then move up to the 5-10% risk category.
And the NNT drops quite a bit,
Wow.
down to 335. So more benefit becoming apparent there.
And for our patients who've already had a cardiovascular event, secondary prevention, high risk.
The NNT is much lower again, 165. You only need to treat 165 of those high-risk patients for 5 years to stop one additional event. It really drives home where the biggest impact lies.
It really does. That secondary prevention figure is quite striking. You can see the immediate value there.
Definitely. But it also highlights the conversation we need to have with lower-risk patients. The benefit is smaller per person, but still potentially important. Understanding the NNT helps us frame that discussion.
It's about shared decision-making, isn't it? Explaining that while, yes, many people in that low-risk group might take the statin without personally avoiding that specific event in 5 years, the population benefit is still there, and for some individuals, it will be the thing that prevents it.
Exactly. And it loops back to what the chapter stresses. Lipids are just one part of the puzzle.
Yes. The whole person approach, always. We have to look at all the risk factors together.
Right. Now, while we're mostly focusing on primary dyslipidemia today, the kind driven by genes and lifestyle, we absolutely have to talk about secondary causes.
Crucial step. Before jumping to conclusions or meds.
Table 78.2 in Murtaugh is your go-to list here. It outlines common conditions that can mess up lipid levels.
Yeah, it's a great checklist. Things like hypothyroidism, nephrotic syndrome, type 2 diabetes, they're all on there.
Cholestasis, anorexia nervosa, obesity, kidney impairment too, even smoking and excess alcohol.
How do these actually cause the lipid changes? Like take hypothyroidism, for example.
Good question. So, with hypothyroidism, lower thyroid hormone levels mean fewer active LDL receptors on the liver cells.
So the LDL cholesterol just builds up in the blood because it can't be cleared effectively.
Exactly. And in nephrotic syndrome, losing protein in the urine triggers the liver to ramp up production of lipoproteins, including LDL and VLDL, to compensate.
Makes sense. And diabetes.
With type 2 diabetes, it's often linked to insulin resistance, which tends to increase triglycerides and lower the good HDL cholesterol. Sometimes LDL can be affected too. Knowing these mechanisms helps us target the underlying issue first.
Right. Treat the hypothyroidism, manage the diabetes better, address the kidney disease, and the lipids might improve significantly on their own.
Precisely. The table also flags things like estrogen therapy and obstructive liver disease. So a really thorough history and exam are non-negotiable. Rule out or treat the secondary causes first.
Definitely. Keeps us from potentially unnecessary long-term medication.
Now, the chapter is very clear that LDL cholesterol, LDL-C, has the strongest link to coronary heart disease risk.
So it remains the primary target for therapy.
It does. And statins are first-line drugs for tackling high LDL-C in most situations.
And this is but we shouldn't just laser focus on the LDL number alone, right?
Absolutely not. That's a key message. It's a vital piece of information, but you must interpret it within the patient's overall cardiovascular risk profile. History, other conditions, other risk factors, they all matter.
Okay, let's run through some of those established facts Murtaugh highlights. Major risk factors for CAD.
Increased LDL, reduced HDL, that's a classic bad combination. And the ratio of LDL to HDL being over 4 is another red flag.
And generally, the higher the cholesterol, the higher the risk. It's a continuum.
Yep. And there's that important threshold for triglycerides too, over 10 millimol.
Big risk of pancreatitis, something we really want to avoid.
Definitely. And again, management always depends on the other cardiovascular risk factors present. It's not a one-size-fits-all based purely on the lipid numbers.
The chapter quotes a powerful stat. A 10% drop in total cholesterol gives about a 20% reduction in CAD risk after just 3 years.
That's significant. It shows the impact quite clearly. It's a good one to share with patients, helps motivation.
And reinforcing the benefits of LDL lowering with statins. Fewer heart attacks, fewer strokes, less need for procedures like stenting or bypass.
And ultimately, fewer deaths. That's the bottom line.
So given all this, what are the screening recommendations?
Standard recommendation is a fasting lipid profile every 5 years, starting at age 45 for the general population.
But earlier for Aboriginal and Torres Strait Islander people.
Yes, crucially, start screening from age 35 for Aboriginal and Torres Strait Islander individuals, acknowledging the higher background risk.
And what if someone falls into a moderate risk category, say, their calculated 5-year risk is over 10%?
Then more frequent screening is advised, typically every 2 years, to keep a closer eye on things.
How do we calculate that risk in practice? What tools do we use?
Good question. We typically use validated risk calculators. The Framingham equation is well known, but the Australian Absolute Cardiovascular Disease Risk Calculator developed by the NVDPA is often preferred here as it's calibrated for our population.
Right, those calculators integrate age, sex, smoking, blood pressure, lipids.
Exactly. To give that percentage risk estimate over 5 years, which then guides our screening frequency and treatment intensity.
And when we do the test, it's the full fasting lipid panel, total cholesterol, HDL, LDL, and triglycerides.
Correct. And a really practical point from the chapter. If you get an initial high reading, always repeat the test.
Why is that?
Biological variability, maybe transient factors like recent illness or diet changes. Repeating it after 6 to 8 weeks helps confirm if the elevation is persistent before making big decisions.
Makes sense. Okay, let's shift gears to management. Lifestyle first, always.
Absolutely. The chapter hammers this home. All patients with dyslipidemia need lifestyle advice and support. It's the foundation.
So what are the key pillars? Weight management is a big one.
Huge. Achieving and maintaining a healthy weight has benefits across the board for cardiovascular health.
And diet is probably the most detailed area, reducing saturated and trans fats.
Yep. Found in fatty meats, full-fat dairy, processed foods, takeaways, deep-fried stuff. Got to cut back on those.
And it's not just about cutting out the bad stuff, but replacing it with better options.
Exactly. Swap saturated fats for mono and polyunsaturated fats. Think olive oil, avocados, nuts, seeds, oily fish.
Cooking methods matter too. Steaming, grilling, baking instead of frying, trimming fat off meat, taking skin off chicken.
All those practical tips help. And watching the snacks between meals, biscuits, cakes, pastries, they often pack a punch of unhealthy fat and sugar.
Fiber is important too, especially soluble fiber.
Yes, from things like oats, legumes, fruits, vegetables, helps lower LDL. The chapter also mentions plant sterol-enriched foods as having a potential modest benefit.
What about drinks? Alcohol and water.
Limit alcohol, ideally 0 to 2 standard drinks per day maximum, and drink plenty of water. Seems basic, but important.
And physical activity, of course.
Can't forget that. Regular aerobic exercise is key, aiming for that 150 minutes of moderate intensity or 75 minutes of vigorous intensity per week.
Plus maybe some resistance training a couple of times a week. And for smokers.
Smoking cessation is non-negotiable. It's one of the most impactful things anyone can do for their cardiovascular health, including lipids.
Family support can make a big difference with these lifestyle changes too, can't it?
Definitely. Having the household on board makes it much easier to stick with dietary changes, for example.
And just to reiterate before we talk drugs, always exclude those secondary causes first. Think thyroid, kidneys, diabetes, alcohol, meds.
Absolutely. Do that thorough workup.
How quickly should we expect to see results from diet changes alone?
The chapter suggests you should see some improvement in triglycerides and LDL within about 6 to 8 weeks if the patient's really sticking to significant changes.
And if the diet works well?
If they achieve good control with lifestyle alone, Murtaugh advises sticking with that for at least 6 months before automatically reaching for medication, unless they're in a very high-risk category where you might start both together.
Okay. But sometimes lifestyle isn't enough, or the baseline risk is just too high, so we move to pharmacological options.
Right. And the choice of drug, as Table 78.4 outlines, really depends on the specific lipid pattern we're dealing with.
That table is great, lists the classes. Statins, resins, fibrates, others. Gives examples like atorvastatin, simvastatin, cholestyramine, gimferbazil, ezetimibe.
Yep, typical doses, what they target, cholesterol versus triglycerides, potential side effects, and the monitoring needed. Really practical summary.
So the general approach starts with,
For high LDL-C, it almost always starts with a statin.
but if the target isn't met or the patient can't tolerate the statin,
Then you consider adding something else as ezetimibe is common, maybe a bile acid resin, or even nicotinic acid in some cases, or using those alternatives as monotherapy if statins are a definite no-go.
let's break it down by lipid profile. Hypercholesterolemia, especially high LDL.
Statins first line. They give a good whack to LDL, typically 30–50% reduction. Main side effects to warn about are GI upset and muscle aches, myalgia. Significant LFT changes are actually quite uncommon.
And monitoring for statins, baseline LFTs, ALT, maybe AST, and CK.
Yes, baseline ALT and CK are recommended. Then repeat LFTs maybe 4–8 weeks after starting or increasing the dose. After that, routine LFT monitoring isn't usually needed unless symptoms develop. CK only needs checking if they get muscle symptoms.
What if someone genuinely can't tolerate statins due to muscle pain, even after trying different ones or lower doses?
That's where ezetimibe comes in handy. It blocks cholesterol absorption, gives about an extra 15–20% LDL reduction, can be used alone or very effectively added to a statin if tolerated.
And the bile acid resins, like calcineurin?
They work, lowering LDL by maybe 15–24%. But as the chapter flags, the GI side effects constipation, bloating can be a real problem for adherence. Tough for some patients to take long-term.
Fibrates, sometimes used for cholesterol.
Primarily for triglycerides, but they can have some LDL lowering effect. Might be an option if other agents aren't tolerated, like fenofibrate. But need caution in renal impairment.
Nicotinic acid.
Lowers LDL, lowers triglycerides, raises HDL. Sounds great, but the side effects flushing, gastric irritation, potential for gout, or raising blood sugar limit its use. Needs slow titration, taken with food.
And the newer injectable ones, PCSK9 inhibitors.
Of ilacumab, very potent LDL lowering. Generally reserved for severe cases like familial hypercholesterolemia or documented statin intolerance in high-risk patients who haven't hit target. Specialist territory often.
What if LDL is really resistant? Still high despite a statin?
Combination therapy is the way to go. Statin plus ezetimibe is a very common and effective combo. Statin plus a resin is another option.
Okay, shifting to high triglycerides now. Moderate to severe elevation, maybe isolated.
Fibrates are the main players here, gemfibrozil or fenofibrate. Aim is to lower triglycerides and reduce pancreatitis risk at very high. Response can be slow, need to watch LFTs, small risk of gallstones and myopathy.
And fish oils. High dose omega-3s.
Yes, N3 fish oil concentrates, often at doses of 2 to 4 grams per day, can be a useful adjunct for lowering triglycerides.
What if fibrates in fish oil aren't enough?
Could consider adding nicotinic acid. And really hammering home the lifestyle stuff, especially alcohol reduction, is vital for triglycerides. Statins aren't primary for TG lowering, but might be used if overall CV risk warrants it.
What about really massive hypertriglyceridemia, like TGs consistently over 10?
That's high risk for pancreatitis. Often needs aggressive combination.
Hmm.
Fibrate plus high-dose fish oil, maybe nicotinic acid too, often requires specialist input.
And the mixed picture. High triglycerides and high LDL.
Depends on the balance. If TGs are only moderately high, say under 4, and LDL is the main concern, a statin is usually first. If TGs are higher, over 4, a fibrate might be the initial choice to tackle that first.
Can you combine treatments?
Yes, sometimes combinations like fish oil plus a statin or a fibrate plus a resin are used. But the chapter specifically warns against combining a statin with gemfibrozil due to the significantly increased myopathy risk. Fenofibrate is generally considered safer if a statin-fibrate combo is absolutely needed, but still requires caution.
Good point. And briefly, familial hypercholesterolemia, FH.
It's a dominant inherited condition, causes very high LDL from birth, leads to early CVD. Need a high index of suspicion, rule out secondary causes like nephrotic syndrome mimicking it, and often use specific criteria like the Dutch Lipid Clinic Network criteria for diagnosis. Referral is usually appropriate. Now, a few special considerations for practice. Always get at least 2 separate lipid measurements before starting meds, right?
Yes, from an accredited lab. Confirms the level is persistently abnormal.
And be aware of other meds the patient is on beta blockers. Thiazides, they can nudge lipids the wrong way sometimes.
Good reminder. What about how long treatment lasts?
Often lifelong, especially for secondary prevention or high primary risk. But, as Murtaugh notes, consider deprescribing in the very frail elderly, maybe over 75, if life expectancy is limited or the focus shifts to quality of life. It's a case-by-case judgment.
And follow-up testing. Lipids, LFTs.
Lipids maybe every 6-12 months once stable on therapy, unless adjusting doses. Avoid overtesting. LFTs, ALT and CK, mainly around initiation or if symptoms arise. Routine, ongoing LFTs aren't strongly pushed anymore unless indicated. What about specific groups, children?
Generally, hold off on drugs unless severe genetic hyperlipidemia. The long-term benefit data isn't there, and risks might outweigh benefits seen over decades. Focus heavily on diet and preventing smoking. If meds are absolutely needed, resins are considered safer.
The elderly, say over 75 for primary prevention.
Evidence gets a bit murkier there. The chapter mentions studies suggesting statins for primary prevention in the over 74s might not cut mortality or overall CVD much. Maybe a small benefit in elderly diabetics up to 85, but for secondary prevention in the elderly.
Still beneficial. If they've had an event, age isn't a barrier to statin therapy for secondary prevention, the benefit is clear.
Pregnancy.
Lipids normally rise during pregnancy, usually settle afterwards. Systemic lipid-lowering drugs are generally a no-go due to potential fetal risks. Focus on diet until after delivery.
And complementary therapies. Fish oils, garlic, plant sterols.
Murtaugh touches on this. Policosanol, plant sterols, might offer modest cholesterol lowering in some studies, but fish oils. The big Cochrane review found no real benefit for preventing cardiovascular events despite their effect on triglycerides. Evidence for vitamin E, garlic, lecithin is lacking.
So rely on the proven stuff mainly.
Pretty much. Lifestyle and evidence-based medications. The chapter also points to patient education handouts in Murtaugh's patient education book, which can be useful.
Okay, let's try and summarize the key takeaways from this deep dive. Dyslipidemia, critical risk factor, needs a patient-centered approach.
We've covered the classifications, the strong link to CAD, the importance of ruling out secondary causes.
Talk through screening, the PBS criteria for starting meds based on risk and levels, and the treatment targets like aiming for LDL under 2.0, total cholesterol under 4.0.
And hammered home that lifestyle diet, exercise, not smoking, is the absolute foundation for everyone.
Then for drugs, statins are first line for LDL, but we have other options like ezetimibe, fibrates for triglycerides, resins, all with specific uses, side effects, and monitoring.
And we touched on special groups, kids, elderly, pregnancy, where the approach needs tailoring.
All of this directly impacts what you do day to day in clinic, assessing risk, interpreting results, talking through options with patients.
And for you registrars studying for exams, knowing this chapter inside out, understanding the guidelines and the rationale behind them is really essential.
So we hope you'll take this information, reflect on your own practice, maybe identify areas to refine your approach to managing dyslipidemia.
Definitely worth revisiting Chapter 78 in Murtaugh and the NVDPA guidelines for the full detail.
And maybe a final thought to leave you with.
Yeah, something to mull over. As our understanding of cardiovascular risk keeps getting more sophisticated, how do we best bridge the gap between population-level guidelines and the individual patient sitting in front of us? How do we truly personalize lipid management beyond just the numbers on the page?
That's the ongoing challenge, isn't it? Continuous learning and critical thinking. Well, thank you for joining us for this comprehensive look at dyslipidemia here on Beyond the Stethoscope, the podcast for general practitioners.
Hope it was valuable for your practice and study.
We'll catch you next time.